amazing work with us. My name's Carrie Koleski, and I'm from Toronto, Canada, a researcher, and really excited to be one of the moderators for the session today. So this is session 1C, just to make sure you're in the right place, enabling better outcomes for older people in the community in collaboration with aging and frailty and intermediate care special interest groups. We also have live streaming, so some people are joining us from elsewhere. So welcome, find your seats. And each speaker has about 10 minutes, followed by 5 minutes of questions. If they take 15 minutes, then we're just gonna move on to the next speaker, and we'll try to entertain some questions at the very end of the session. So come on in, welcome. We're gonna start with a presentation called Hearing Care as part of Basic Care in Senior Home by Claire Tollenaere.
Good morning, everyone. Good morning, ladies and gentlemen. It's nice to be here at this wonderful congress in my home country, and I want to thank the organizing committee to have the opportunity to talk about the project of Ahosa, an organization I volunteer with. Ahosa is a non-profit organization that works for hearing impaired people who communicate in spoken language. Most of the members have become deaf or hard of hearing during their lifetimes, so the causes of the hearing loss can be very different, of course.
What do you want me to do?
One of the recent projects of the organization is putting hearing care in a senior home in the spotlight. Experiences with and testimonials of elderly people show that the impact of being hearing impaired is underestimated. The attention for hearing has to be a basic part of care in general. So the next 10 minutes, I will try to convince you all that hearing well and attention for hearing loss are very important. Sensibilization and correct information can make a world of difference for those who face everyday frustration, communication errors, and isolation. Sometimes numbers are needed to give us a correct image of the prevalence of a problem. What we know is that hearing loss is spread worldwide. 1 in 6 people is hearing impaired. And in Belgium, we see that more than 9% of the total population is hearing impaired, and in adults, this is more than 11%. Age-related hearing loss is the most frequent cause. In a senior home, this is 80%, as the average age is about 87 years. But in most cases, it is an invisible handicap, because you see that only 33% is wearing a hearing aid. But what do we know about the impact? People with hearing loss don't hear the ringing of the phone, a simple knock on the door. Listening to the radio or television become very difficult, and alarms are not picked up. In many cases, elderly people feel confused and anxious because they don't understand the situation. For them, all of a sudden, things happen, totally unexpected. Sometimes communication is not that easy. Caregivers and family talk without paying attention to the hearing impaired person. That means sometimes they talk too fast, unclear, without looking at the face, not waiting for a reaction because they think there is no time for it. The circumstances are often not good. Not enough light, face masks hinder smooth communication.
Yeah, let's go back to the speaker.
The reason why people forget the hearing impaired is that they just don't know what are the risks or the impact of hearing loss. They just don't know that innovative technologies can help to avoid problems, and that some interactional adaptations can improve the quality of life. They just don't know that all these things don't take too much of their time. There is a link between the hearing loss of elderly people in a senior home and the quality of life in general. That means people get isolated, lonely, and or depressed. Communication becomes difficult, and many studies show that the progress of the process of dementia is getting faster. Ahosa found that it was time to start a project that puts hearing and not hearing into the spotlights. What we try to give the hearing impaired residents a higher feeling of safety and participation, better contact with caregivers and family, and so less secondary problems. We hope to install a workable protocol in all senior homes in Flanders, and why not in the whole country of Belgium, or even in other countries. Let me dream. Probably my presentation will be a wake-up call for everyone and can be an occasion for exchanging ideas, views, and good practices that maybe already exist. So how did we proceed? Well, this year we started with the organization with a pilot project in one senior home. A team of Ahosa gave training sessions for the whole staff with a lot of theoretical and practical information, using didactical material, and with time, certainly time for interactions and practice. In a 3-hour session, the participants received anatomical and physiological information about the ear and how we hear. Also, what the causes are of hearing loss, and more importantly, how can hearing loss be treated? So they got an overview of technical solutions, different types of hearing aids and other hearing instruments that can make individual and group conversations easier. And last but not least, they could find out how a few communication techniques can help to avoid frustration and misunderstanding. After each session, we asked the staff to fill in a questionnaire, and we asked them for feedback, because we can use all their advice to improve the training. We also made a questionnaire for the residents themselves with easy questions to answer, such as always, sometimes, or never. The themes of the subjects were participation, communication, well-being, and hearing devices. The residents were asked to answer the questions twice, namely before the start of the project and also 3 months later. And the aim was to see if there was any progress concerning hearing on the impact on their daily lives. To give this project more scientific body and to make it future-proof, we asked for the cooperation of the Artevelde University College of Ghent. A student of the Department of Audiology made a thesis about this theme and helped us with the ear screenings, the processing of the numerical material, the development of material, and the making of conclusions, and of course the research of scientific publications. What about results now? Well, as I already said, our research, screenings, and questionnaires are based on the data of Eurotrack Belgium 21 and on the World Report on Hearing that give us numbers of hearing loss in Belgium in the last few years. Concerning the ear screening in the senior home of our pilot project, that proved that all residents have hearing loss, all of them, but only 21% of them is wearing a hearing device, which is less than what Eurotrack numbers gave us. Then concerning the questionnaire of the residents, here we can see that there is a significant improvement in terms of communication rules. Namely, the staff pay more attention to the way of talking and involving the residents. Unfortunately, group activities remain difficult, and there is no difference in the use of hearing devices. So we can conclude that more coaching is needed. Concerning the feedback of the staff, it was very positive in general, but of course there is still room for improvement. After 3 months, many of the caregivers dedicate that there was a change in their behavior toward the hearing impaired. So during this year, we developed a PowerPoint with a text and an instruction film with daily life scenes in the senior home, an information leaflet for the person with hearing loss and his entourage, and last but not least, symbols to signal the hearing loss in every room of the hearing impaired patient. So we all know that this is just the start of something big. This was a small-scale internal investigation within a pilot project in one senior home. There is really need for a large-scale research and guidance for hearing and hearing loss. The whole society in general and specialized teams in particular have a responsibility in this material. Thanks to all the feedback we received from the participants of the training sessions and the residents, we can improve those training sessions in the future. And there was so much positive feedback that supports us and that gives us wings to fly higher. We will also work on an e-learning program. First of all, because it is more comfortable for the staff to be able to choose the training moments themselves. And the second reason is there are more than 800 senior homes in Flanders, so it is impossible for the trainers, almost volunteers, to give 800 times 5 training moments. We are looking for people who can help us to make contact with umbrella organizations of Flemish senior homes, and I hope this Congress will be an occasion to meet some of them. And sometimes it's better to start with one in a small region than to see it bigger from the beginning. And as I have said, the final goal is to realize a hearing protocol. I hope we will receive much support in the future. And certainly we all work to obtain more attention for hearing in general. Why not via a national screening from the age of 50? But that's another discussion, I presume. So I want to thank you for your attention and your willingness to hear, to listen, and to understand. And I thank everyone who's working at this project. And I hope that I have inspired you to think about hearing care in senior homes. Thank you.
Thank you so much, Claire, for that really inspiring talk about a really successful program to address hearing loss developed locally. And it sounds like there's a huge opportunity to spread and scale this program elsewhere. We do have some time for questions. I wanted to invite the audience, if you do have a question for Claire, now is the time. When you ask your question, there is a roving microphone that you'll have to use so people online can hear your question as well. Any questions from the audience? If not, I'm going to steal your airtime and ask a question. Okay, I have a practical question for you, actually, Claire, very quickly. And so if I'm a manager in a seniors home or a long-term care home, and I'm seeing this study and really excited about the results, what would I do to get started? So what's one thing I could do today to start to kind of pull in some of the learnings that you've had in your program?
Well, I think you, as a manager of a senior home, you have to be conscious that hearing, and hearing well, is very important, and that you can talk with your staff. What shall we do about it? But here, I think the client is very important too, that he can give something to the caregivers, how to react, that he can say, I don't hear it. So we have also to make the clients conscious about their hearing loss too. And sometimes that happens too little in a senior home, I see. Yeah.
Right, thank you for that. So creating safe spaces for people to feel comfortable to articulate those concerns. So thank you very much.
Okay, thank you.
So thank you, Claire. I'd like to invite Margaretha van Dijk to the stage, and she'll be talking to us about a study called Development and Feasibility of the Geriatric Activity Program Pellenberg, with the caregiver as an exercise partner. So thank you very much. Take it away.
Thank you. Thank you. I'd like to thank the organization for giving me this opportunity to present my work. To understand where I'm coming from, I have to tell you a bit more about my workplace. But it's not working. Yeah. Okay, so I'll work on a geriatric rehabilitation board. And I just want to introduce you some of my patients. So we have Angela, who's 89 and who had a hip fracture. We also have Julien, who's 75 and he had a stroke. And we have Godelief, who's 88, and she had a bypass femoralis, tibialis, posterior. And we have Roger, who's 86 and he had a steroid myopathy. So they're quite different people. And there you see the ages also. We have a mean age about 84 on our ward. So we have a group of hip fractures and surgery. We have a group that had a stroke. We have a group that had surgery. And we have a group that we call others, because there's everybody from the acute hospital comes to us if they can't return home immediately. So these patients are a very generous group, but they have one goal, and their goal is return home. So we looked at literature to see if there are some therapy programs that we can give them in order to achieve this goal. But there were not for this particular heterogeneous group, and also for 5 days of therapy a week. So we developed our own Geriatric Activity Program Pellenberg, which consists of 45 minutes of physiotherapy a day, with different teams to make their functional capacity better. So this worked quite well, and you see how active they are during the therapy. They're doing weightlifting, doing speed exercises. But the other thing is, outside of therapy, they're not really active. And that's a problem. Because the the guideline of the World Health Organization for 75 plus says that you need at least 300 minutes of moderate intensive exercise per week to improve your health. And that's what we're trying to do, improve their health. So how can we make this work? Because we only have 45 minutes a day, and this is not enough. So how can we increase the activity outside of therapy? Well, there are some difficulties for this population, because most of them, they need physical support or supervision to actually move and walk, because if they can walk independently, they go home. So staffing and financial restrictions make it impossible for either nurses, physiotherapists, or occupational therapists to take this task on. Because I think it's everywhere the same. You're minimum staffed, so you're thankful that you can just do your job without doing any extras. So, of course, what else can we do? Can we make the caregiver an exercise partner? And this way, caregiver, I mean the informal caregiver, so a family member, a friend, a neighbor, somebody from the community. We think that would be a good idea because it would further improve functional performance of our patients, but it would also give the caregiver insights in the capacities and needs of the patient. So we did a review of the literature first, and we saw that if we get caregivers to become exercise partners, it actually has beneficial effects, especially immediately after the intervention and in the first 3 months in follow-up. The other thing that's really important is that caregivers are willing to get involved up to 6 times a week, which is quite a lot. But also caregivers need multiple hands-on teaching, so you can't just give them a course or a presentation of half an hour or an hour and then think they can do it. They actually need to be taught how to do it and really hands-on and experience what they had to do. So we took this and made a prototype of GAPP+Care, and we proposed that in hospital, outside the physiotherapy is given, we would have 4 care sessions per week of 30 minutes, and one of these 4 sessions will always be with a physiotherapist. And then we think that after discharge, it needs to be prolonged a little bit more, because physiotherapy normally goes back to 3 times a week. So we thought care sessions should prolong for another 6 weeks after discharge. And then we made a booklet, and we made different ones, with exercises and some explanations, and as a tool for the exercises. So we developed this, and then we wanted to know, okay, we developed this for the patients and their caregiver, but what do they feel about this before we start implementing? So we did semi-structured interviews with the patients and the caregivers, where we first explained what we wanted to do, and then we gave them the prototype of the exercise booklets, and then asked questions about 3 domains. Were they willing to participate, and why? What were the reasons if they wanted to? What did they think about the exercise moments, about the number of exercise moments, but also the duration, the time, when it's supposed to happen, in the evening or the weekends? And then we asked questions about the exercise booklet. So 16 patients and 15 of their informal caregivers took part of these interviews. And on the question if they wanted to participate, it were 75% of the patients, and a little bit more of the family caregivers, it was 80%. Then we asked especially about the 4+ care sessions, since the studies showed that caregivers were willing to participate 6 times a week. But with this particular group, they said, well, 52 said yes, they would agree, but actually 45 preferred less. And of course, we wanted to make, when we started implementing it, to be broader to an audience, so we changed the 4 sessions to 3 sessions. So about the booklets, they didn't really have any comments. They found it really clear, only the symbol explaining how to make an exercise easier or more difficult, which we used the color code, they didn't understand. So the result was we had 3+ care moments, and we made the booklet a little bit easier and saying this is easier exercise, and this is how you make the exercise more difficult. Then we started the feasibility of GAPP+Care, and where we wanted to implement this and see how it would work. So the aims were how many patient and caregiver diets would actually participate, but also what's the difference of those who we think are eligible and how many are actually participating. And then we also have questionnaires at the end of the hospitalization and at the end of the intervention to see what their opinions were about GAPP+Care. So the results were that we had 281 patients on the ward in that year. Of those, 89 patients were eligible. Then we started to ask them if they had the caregiver who would be willing to do this, and 40 had none. And it doesn't mean they didn't have family, but most of them didn't. But sometimes it's also if they are available or not, and sometimes they're living abroad, or they had a full-time job, or they have to look after their grandchildren. So that's why we come to this amount of 40. And some refused. And sometimes the difference between having not a non-available caregiver or a refusal was different, because some people say, no, I can't do it. I don't want to do it because I work full-time. And others say, I don't have a caregiver because they work full-time. So there's a line. I don't know if it's really correctly. That's how we said refuse or no caregiver. But in the end, we only had 13 patient-caregiver diets in 1 year. So that's not very much. So in the questionnaires, the positive things that come out is information. Caregivers liked the information. They had questions for me every week. They liked to know how to help their family member. And they find it very, very useful. They thought, yeah, this is much better than just sitting around here doing nothing. The negative thing that we found was especially after discharge. Then the time to spend 3 times a week was more difficult because all other things come, like doing shopping, doing laundry, and which they didn't have to do while they were in hospital because everything was taken care of. And also a little bit negative about the partner becoming a therapist. So if it were the children, it was a little bit less, but especially with a partner, it sometimes was like, yeah, he didn't want to do, and now I have to tell him he has to do it. So that's played a little bit of a role as well. So the conclusion here is that patients do like to work hard, even if they're over 80 years old. Caregivers are willing to participate in a program where they do exercises with their family members, but the availability of caregivers in this particular age group is not as much as we anticipated. And in hospital seems to be working much, much better than at home. So mind the gap and take care of your older people.
Thank you so much, Margaretha. That was really, really interesting to learn how you engaged, caregivers and patients in, designing the actual intervention and then talking through some of the outcomes and some of the challenges. Any questions from anyone in the audience? Over here, and can you bring a microphone over here if you have one available? No? Okay, go ahead and I'll repeat your question so people can hear online.
Thank you very much for your interesting story. Very nice. We also did in Amsterdam a kind of project the same like you, very small, and we also had the same problems that we could not find enough caregivers, informal caregivers to participate. Do you have any idea of what the solutions could be on that for the future? Because I think it could be a nice solution to have more therapy.
Yeah.
Yeah, and I'll just quickly repeat that question for people online. So a friend from the Netherlands also implemented a similar program and found that it was hard to engage and find caregivers to participate in the intervention. So some comments from our speaker. Hopefully I captured the essence of that correctly.
Thank you for your question. I think one of the solutions might be working with volunteers. I think there's some research done in the community. We also discussed if we wanted to use volunteers, but with our hospital, it was difficult because volunteers aren't allowed to touch patients. So that's the safety issue going. But maybe in the future we can change that and saying if we train the volunteers so they are allowed to do that. I think that would be an option because I still think the caregivers that are available, we should get involved, but there's this really large group that just don't have caregivers available. So volunteers, I think, is the way to go.
Thank you. We do have time for one additional question. I thought I saw a hand go up over here somewhere. Yes, in the back.
We were asking about whether you use volunteers. Using volunteers around things like, if the patient had a fall whilst doing the exercise with the volunteer and how that happens. That's what we're asking. Is that very question?
Okay. So similar question about the use of volunteers, given the difficulty in finding caregivers. So any further reflections on that?
Well, as I said, I think it's a very good idea, but for us in our hospital setting, it wasn't allowed at the moment. But.
Excellent. Any other final thoughts, questions before we move? Oh, yes, I'm sorry. Sir, over to you.
Have you considered to replace the booklet with digital version and involve the caregivers digital so that you do not have to go as often, maybe even have some of the exercise together virtually?
Yes. Do you want to
Yeah, to go ahead. Yeah,
okay. Yes, we did consider that, but our population is, because they're over 80 and we have little percentage that actually really use smartphones and all the applications, and even some of the caregivers don't really use that. But I think it is really the future, and we should start doing it. And last week we were talking to a company to see if we can get it more digitalized. But we decided for now not, because I think about 30% have a smartphone on our ward, and that wasn't enough for this study. Yes, but we wanted to have something that we could implement and sustain. And if you start providing that and you have to take it home, then it already stops when your study stops.
So it sounds like we need a tech partner. Any tech partners in the audience? Anyway, thank you very much. Great presentation. So now we're moving on to our third speaker. So Sanne Tent, I invite you to the stage, and she'll talk to us about a study called Prioritized Health Outcomes of Acutely Hospitalized Older Patients.
Well, thank you for the introduction, and Also, thanks to the organizing committee for the opportunity to present my research here. My name is Sanne Tent and I'm from the University Medical Center in Groningen, the Department of Geriatrics. I'm a PhD student there and I will talk to you in the upcoming minutes about the prioritized health outcomes of acutely hospitalized older patients. And as an addition to the plenary session this morning, you might all now know that inpatient-centered care is very important to elicit goals, to place focus on what's important for the patient in daily life, and also when there's multimorbidity or polypharmacy to look at universal health outcomes instead of disease-specific health outcomes. And it also puts patients in control to when difficult treatment decisions have to be made. And from previous literature, we know that in daily life, older patients find maintaining independence very important. And especially in acute care, goal elicitation is very important. The time pressure is even higher than in the rehabilitation setting or in elective care. The first steps of treatment are very important for the overall hospital outcomes, and also they cannot be reversed once they are initiated. It can also mean that once knowing the goal, the medical specialist can choose to admit the patient to the hospital or send them back home. And from literature, we know that goals change according to the health state of the patient at that moment. So the acute disease can have an effect on the importance of maintaining their independence that was found earlier in studies. And so far, no studies have looked at the goals of acutely hospitalized older patients, so that was our aim, and also to find which patient characteristics were associated with this goal. To do so, we made use of the acute lines data and biobank. This is a data and biobank at the emergency department at the University Medical Center Groningen. And it aims to map the complete acute patient journey. So from the start of the from the onset of the acute illness till well after the hospitalization, up to 5 years or even till mortality. And this, they aim to prevent the fragmentation of care throughout the acute patient journey. Of the patients that are in that data and biobank, we selected the patients that were older adults, aged 70 years or older, which were acutely hospitalized after visiting the emergency department, and they had to be visiting the emergency department between September 2020 and December 2022. We included several patient characteristics as part of the geriatric assessment, which included somatic, psychosocial, social, and functional domains. And to establish the goal of the patient, we used the outcome prioritization tool. This tool was assessed within the first 24 hours of the hospitalization. And in this goal, patients have to prioritize between 4 universal treatment goals or universal health outcomes. And these universal health outcomes were life extension, preserving independence, reducing pain, and reducing other symptoms. This tool makes use of the trade-off principle, so neither of the 4 goals can be rated equally. A score can be given from 0 to 100, and a higher score means giving more importance to that goal. And although it is developed as a conversation tool, we used it as a self-assessment tool. So we gave the patients a written instruction, and they could fill in the tool. We included 389 patients in our study with a median age of 75. 3% of these patients lived in a dependent living situation, and the comorbidity score was around 5. Most complaints were in the somatic area, and most patients experienced mobility problems, and there were problems with pain and discomfort. And now for the prioritized health outcomes, we also found that maintaining independence was prioritized most, where after reducing pain, extending life, and reducing other symptoms were prioritized. And as we were interested in the associated characteristics with the main health outcome that patient prioritized, we compared the characteristics between maintaining independence and the other three universal health outcomes taken together. And we found that once patients prioritized to maintain their independence, they had a lower comorbidity score and there were less cognitive impairments present. So for the discussion, we found that for 89% of the patients it was feasible to complete the OPT correctly. So they were able to prioritize one of the 4 goals. And as I said, maintaining independence was prioritized more than life extension or reducing pain or other complaints, despite the influence of the acute disease. And ideally, you would like that goals are already established before the acute moment of the disease to really know what is important for the patient in daily life by, for example, the general practitioner or in another environment. Taken that together with the fact that once goals are not explicitly listed by medical specialists in the hospital, and they are, after a conversation with the patient, asked to estimate the goal of that patient, they are not able to correctly estimate the same goal as the patient in 6 out of 10 cases, if I'm correct. So taken together with the result that it's still very important for the patient to maintain their independence found in our study, this really emphasizes the importance of goal elicitation at the start of the acute hospitalization. There are also some limitations to our study because the OPT is developed as a conversation aid. It is never validated as a self-assessment tool. We also do not have any information on why 60 patients did not correctly complete the outcome prioritization tool. So we cannot establish further why, what was the problem with that. And we only performed this study at one hospital, giving it some generalizability problems to other hospitals. And what I would like you to remember from this presentation is to be aware of the importance of goal elicitation, especially in acute care. Once goals are listed, treatment can be aligned to what is important for the patient in daily life and at that moment, so that optimally integrated care can be provided to the patients who are overwhelmed by their acute disease. I would like to thank you very much for your attention.
We found the microphone. Amazing. Okay, got it. Okay, okay, thank you very much. Any questions? Thank you for that wonderful presentation. I love the goal elicitation tool, and I wasn't surprised at all to see that maintaining independence was like one of the key things and key priorities for patients, and also not surprised that medical specialists felt differently, that they didn't really fully, understand that might be the first and top priority. So I'm trying to get a little debate going. Question at the back, and I will come to you. Test. Friend and colleague, Karen, hello.
Okay, coming to you.
Thanks, that was a great talk. I was just wondering, I noticed that your recruitment period was during the pandemic, COVID pandemic, and where I practice in Toronto, Canada, the type of geriatric patient that was admitted during that time period is very different than outside the pandemic. And so I just wondered if you could share kind of your thoughts on how the pandemic may have affected your type of participants and perhaps also your outcomes.
Well, thank you for your question. We did not really look into yet if the pandemic really influenced our results. That's still ongoing. But I can imagine that there is an effect because, what you said, there are different, another patient group that might have visited during that period. So for now, I cannot give an answer to that, but maybe we can discuss it later over a cup of coffee.
The networking has begun. Any other questions from folks in the audience?
Okay, let's go wide.
Okay, I do have one. Oh, I won't get my question in.
Let's find the person.
Thank you very much for the interesting presentation. I'm a researcher in geriatric rehabilitation, and I'm surprised by the high rate of patients that were able to fill in the form, because in my setting the nurses indicate that a lot of the patients are not fit enough to set goals or to have a talk about setting goals, and that's even a post-acute phase. So I'm surprised about the high rate. Did they get any help, or how can you reflect on their abilities to fill in the form?
Yeah, I think for sure. Thank you for your question. I think for sure we have a skewed fill-in rate because when people could not fill in the questionnaire, they would also definitely not have filled in the outcome prioritization tool. And there was a student assistant there to help when there were questions. But I do not have insight at this moment to which extent patients asked for help. But I can imagine that we have the fitter or the less cognitive impaired patient group because they could fill in the complete questionnaire.
Okay, thank you. Thank you.
Okay, let's go wide again.
So we have time for one quick question. Oh, a couple minutes, okay. So I wonder, any other questions? I'm not scanning very well. What are the next steps in your work? It seems that it's really interesting. There's some, like in any study, some limitations, maybe things you do differently. If you were to do this again, what would that look like? Or what are the next steps for you in this work?
Well, for the next steps, I think it's really important to implement this into the daily practice at the emergency department, to be there when the patient is admitted and to already establish the goals at that moment. Because it's a very hectic phase, and as I said, the treatments are irreversible once they are started, and also make the acute physicians aware of the importance of goal elicitation. So that would be the next step. So make the physicians aware and implement goal elicitation already at the first phase of the acute admission.
Great, so doing it more proactively and then educating physicians on the importance of doing that. And one quick follow-up, because we do have another minute. What do you do, because people have, obviously if you're a clinician or if you're a patient or a family member, kind of different priorities, and we talked about that for those that went to the opening plenary. There's some disagreements based on, the scopes of people's practices, what their priorities are. Inevitably, there's differences in what people think is or should be most important. How do you manage that? Is that part of your research program and kind of figuring out how to deal with those difficulties that might come up with disagreements around goals?
Well, it's not part of my personal research program, but I can imagine that it's also a very interesting follow-up question to do some qualitative research on how to improve those areas. So it should be definitely a point in further research.
Thank you, and I'm trying to seek you out as a research partner, pulling in some areas of interest. So thank you very much for your presentation and your questions and answers. So switching back to this mic, I'm going to invite Silke F Metzelthin to the stage, and I blame it on my Canadian accent if I mispronounce anything. She'll talk to us about an example of conducting participatory action research within the Living Lab in aging and long-term care, developing, evaluating, and implementing a reablement training program. So take it away. Thank you.
Thank you. So good morning, everybody. My name is Silke F Metzelthin. I work as an assistant professor at Maastricht University, and I'm also employed as a linking pin at our Living Lab. And hopefully within the next 15 minutes, you know what a linking pin is and what a linking pin does. So I would like to introduce our Living Lab to you, and I also would like to give you an example how we conduct research within our Living Lab. But first of all, why did we decide to establish a living lab in aging and long-term care? So as you all know, we have to deal with an aging society with complex healthcare needs, and at the same time we have to deal with the reduction of financial resources and well-trained staff. So this requires evidence-based, innovative care approaches. However, the problem is in long-term care that we do not have a long tradition of scientific research, and at the same time it also takes a very long period of time before the research come into practice. So it takes on average 17 years, and on top of that only 14% of the scientific research ends up in practice at all. So these were reasons to establish our living lab. And first of all, I would like to give you a brief description of the living lab. So it's not a physical space, it's a network. So it's a structural collaboration between 4 educational institutes, so our university, a University of Applied Sciences, and 2 vocational training institutes. And we collaborate with 9 big healthcare providers in our region in the south of the Netherlands. And together we cover round about 185 locations, which is equal to 27,000 staff members and round about 50,000 clients. And our mission is to improve the quality of life of clients and their informal caregivers, to improve the quality of care, but also to improve quality of work. And our living lab knows several key characteristics. So first of all, it's interdisciplinary. So both the researchers, but also the care staff have a background in different disciplines, like nursing, medicine, occupational therapy, physical therapy, and so on. And it's a tailor-made approach. So each organization, of course, is organized in a different way, and also each organization has a different research agenda. So you really have to adapt your work to the needs of the organization. And finally, we also work with joint appointments, the so-called linking pins. And we have scientific and practice linking pins. So a scientific linking pin is a person like me, a senior researcher who is working for Maastricht University, and we work 1 day a week for one of our partners. And at the same time, we also have practice linking pins. So this is the other way around. These are employees who get 1 day a week to work on our research projects and to help to facilitate and develop and translate scientific research to practice. And in my case, because I'm working at a very big organization with around about 5,000 employees, I have 2 practice linking pins, which are shown below. And we have some goals and activities during our work. So first of all, we really want to build an infrastructure for scientific research within the organization. So for me, it's very important to be in touch with different people within the organization. So on strategic level, on tactical level, but also on operational level. So for me, it's important to know what is their strategic agenda for the upcoming years, but also to have a lot of conversation with the employees on the work floor to get an idea what are problems they face in their daily work. And together we try to create a research agenda for the upcoming years and to conduct research together to solve the problems in practice. So, and that can be very diverse. So, for example, people who join a working group to develop a new approach, or also people who are involved in an intervention study and are interviewed or participate in a focus group. And as a linking pin, we have also a mediating function. So this means sometimes there are problems in practice. I do not have a lot of experience in. So for example, in voluntary treatment or green care farm, I'm not an expert in this field, but then I know some colleagues of mine who are also working in the living lab and they have the experiences, and I try to match them and to link them. And on the other side, also my colleagues sometimes are looking for locations where they conduct their research, and then I bring them in contact with my partners in practice. And finally, it's also important to disseminate and implement evidence. So we are participating in symposia, organizing symposia for the professionals in the field, but also for clients, informal caregivers. We also translate our research to fact sheets, for example, to make it also easier to assess for the not academic people. And so our model was established already in 1998. So now we have an anniversary this year of 25 years. And in the meantime, also our model has been replicated in other countries. So we have a similar model in the UK, in Germany, and Austria. And of course, we also collaborate within our individual research projects with researchers from other places. So now I come to the example. So my work at Meandergroep. So my research line focused on stimulating autonomy and participation of older adults in daily meaningful activities. And Meandergroep also have a similar interest. They are interested in person-centered care and how they can provide more self-directed care. So during the last 9 years, we worked on developing, evaluating, and implementing innovative care approaches, like, for example, reablement. So for those of you who are not familiar with reablement, very briefly, it's a person-centered intervention where an interdisciplinary team tries to reach the client goals. And these goals can be very diverse, so ADL, IADL activities, but also meaningful activities like going out for a walk or having a cup of coffee with a friend. So during the last years, I went with them to the whole process of developing and evaluating, implementing interventions. So first of all, I got familiar with the evidence about reablement. So I had a look at the literature. I also visited some places where reablement is already implemented. I set up an expert meeting with reablement researchers, and I took all the knowledge back to my colleagues in the Netherlands, and I talked with managers, the board of directors about the ideas abroad. But I also had a working group where we had a look at the specific materials of reablement and how we can implement them in practice in the Netherlands. Then we had also 2 pilot studies, and during the pilot studies I also tried to involve students. So I had 2 nurses who were busy with a bachelor program. So one of them implemented intervention for me, and the other one did some interviews with clients and informal caregivers. And after that phase, we have conducted a cluster randomized controlled trial at Meandergroep, where in total nearly 250 clients participated and 350 staff members. And during the RCT, I also tried to involve professionals during the training sessions for the staff. And I invited them to share their experiences with reablement because they could function as a good role model. And finally, as a researcher, of course, I publish in scientific journals and I visit scientific conferences, but I also translated some of the papers to Dutch, and we also published in the magazine of the healthcare organization. We visited conferences for professionals, and I also invited people who participated in the study to join me to share their experiences. So finally, I have some recommendations for you if you also want to start a living lab. So the first recommendation is to start small. So really look for 1 or 2 partners who are also intrinsically motivated to start up a living lab. and don't be too ambitious in the beginning. So set up some small goals, because in the beginning you have to invest a lot in building up the relationships, and it's also very important to have first successes in the beginning, because it also increases the belief in the model and builds trustful relationships. Then it's also important to show that there is reciprocity, so that it's a win-win situation for all, not only for us as a university, but also for the partners in practice. And finally, it's very important to create an infrastructure within the organization for scientific research. And that can help to work with linking pins, or, for example, set up a scientific committee at the organization.
Okay, switching over to this mic. Thank you so much. That was an excellent presentation, and I have lots and lots of thoughts and questions. It's very exciting. I'll go over to the audience, though, first to see if anyone in the audience has a question. We have one at the back. I'm just going to bring the microphone and then over to Mary Ann after.
Thanks very much. Anne Hendry from Scotland. Very many congratulations, a fantastic innovation and collaboration. How was the funding secured, and how have you managed to get sustainable funding? Because you've been at this a long time now.
Yeah, that's a very good question, and I first had it in my presentation. But due to a shortage of time, I decided to place it in the back. So this is a little bit how the structure or the financial structure looks like. So we have a basic infrastructure for funding. So our partners, they have an in-kind funding, so they make employees available to participate as a practice linking pin, and they also pay a specific amount per year, and they get the scientific linking pin back for it. And since 2017, we have also structural funding from our government, which really gave a boost to the Living Lab, because now we have, for example, also somebody who can concentrate on the communication and a back office to organize everything. And of course, we also apply for regular research money. Yeah.
Thank you, and over to you. Thank you, Carrie. This is a really amazing presentation. I was part of the NO, the European Network of Living Labs. They did a bit of a training session that I was part of over the fall. So I have a sense of the work that you're doing, and that was actually my first question, was around the funding. But another question that I'm also curious about is, to what extent are you embedded within some of the organizations that you are partnering with? I know you have the scientific and the practice linking pins. I'm just kind of wondering, from the scientific end, how are you embedded within the organizations that you're partnering and doing the work?
Yeah. So some of my linking pin colleagues decide to work really one day a week at the organization, so they have their office. But in my case, because I conduct a lot of research in the community setting, it does not make so much sense to me to really sit in one place. So I have appointments at different places with different kind of people. And I regularly meet my practice linking pin colleagues, but also the board of directors, the managers, to have conversations about the strategic plan for the upcoming years. I also meet regularly with the communication people within the organization. And I've also a scientific committee, so we meet one time a month. And that is an interdisciplinary group, so there is a nurse who is working in inpatient care, a nurse from outpatient care, a physiotherapist, a psychologist, doctor, so a diverse group. And I use the scientific committee also to get input, to get an idea what's going on in practice, and also implement the knowledge, the scientific knowledge, into practice.
There were times because I'm tiny. I was just going to say it'd be really great to link in with you after and have a coffee time around research and capability building.
I'll repeat.
Okay.
Yeah,
Thank
so
you.
just an opportunity to link in. There's a lot of excitement from the group today on learning, how to do this in our own organizations. It's such a great opportunity to increase the capability of knowledge translation. I think about things like learning health systems, the importance of being embedded with bringing research and practice together to really amplify opportunities for change. I'm also very excited about this, so we'll chat as well. Thank you.
Thank you.
Over to our next speaker, one of my dear friends and colleagues, Judith Versloot. She'll be talking about population segmentation of older adults with a hip fracture based on hospital and community care trajectories, who waits, gets prioritized, or returns home, and where are the inequities? So take it away, Judith.
Thanks, Gary, and good morning, everybody. Thank you for reading out my rather laborious title. This is a study of databases, just to set you up and change gears a little from all the excitement of people are on the ground. I'm sort of like flying right there. So it's about people who come to the hospital and have sustained a hip fracture. And this is often a tipping point in elderly, where their life changes dramatically. We see a lot of functional decline, a lot of cognitive decline, and quite often people cannot go back to their original living situation. So what is the aim of looking at data of hip fracture patients that go through their journey in the hospital? So we really want to understand which of these care trajectory journeys results in better outcome for which patients. These journeys are not the same for everybody. Yes, perhaps we go to some similar stages, but where you end up, how long you wait, what you get is different. And can we identify what is best for whom? We also aim to gain some insight into different phases of the entire care trajectory. What are the timings of different things, and how does that maybe influence the outcomes? So a typical care trajectory of an elderly person that sustains a hip fracture is they come to the hospital, to the emergency department, they wait for a bed, they wait for surgery, they get surgical repair, with a target time of 48 hours, but we actually know that after 24 hours, your risk of all sorts of negativities go up. After the surgical repair, there's some acute hospital stay, after which most patients need some rehabilitation. This can, and I work in Canada, and there this can be done in the hospital, in a long-term care setting, or as an outpatient from home. And as we saw, many people would like to go home, and that's often the aim. So hip fracture care has some systems challenges and solutions. So some of the system challenges is that because there's a lot of different units in the hospital, as well as a lot of different settings outside, not to mention all the disciplines and everybody involved, there's a lot of fragmentation, a lot of silos, and I think I'm speaking to the choir, people understand that quite well. Luckily, there's also some solutions, like why we're all here. There's integrated care. But how do we do that? And this study is really to inform. If we want to implement integrated care, and in this case, our hospital is very interested in bundling the cost, because if we bundle the cost, we give one central person or institute sort of the responsibility over this cost, can that improve the care trajectory? So we have some needs before integrating and bundling this care, and this is just a little piece of the pie and the puzzle to give us some insight into what do we really need to know, what is going on the ground if we look from above. So the method that we are using in this particular study is care trajectory methodology using healthcare utilization data. Carrie and I were both in Toronto, in Ontario, in Canada, and we work in an embedded research institute. And we have a collaboration with an institute that's called ICES, and they collect lots and lots of healthcare data that the hospitals are mandatory to report to the ministry, that doctors need to report for billing, and also they combine it with some population-based data. So we can sort of see who they are, where they went into the care system. And what we've done, we have split those trajectories. We split them on where they go, their first discharge destination and also the second. I said, this is where we are. Mississauga is exactly the sort of the suburb of Toronto. Our hospital has 3 sites and serves over 1 million people. Some of the variables that we looked at in this study is patient characteristics. So this is, comes from sort of the person databases. We included patients of the age of 65 and older. We know their sex, and we know there are some formulas to formulate the number of chronic conditions in these databases. If we look at the in-hospital data that we have included, we looked at average numbers of hours people wait for a bed. Although we know this is a little bit skewed, because in our hospital we have a lot that is called no bed admits. So according to the record, you're admitted, but you're nowhere near a unit and in a bed. So take some of these numbers, do realize this is what is reported, and definitely not always what is happening in the hospital. We looked at the percentage that had surgery within 24 hours, because the latest research really shows that that is another tipping point, but now in time. And the average numbers of hours waited for the surgery. We looked at the year outcome, and we saw that did these people connected with their family physicians, what was the cost per day, and how many patients died within 1 year. So these are the care trajectories. The dark blue is the first discharge destination, and the light blue is where you go after. So if I give you the example of the first one, they went to inpatient rehab as the first setting, and then the second setting could be long-term care, home and rehab, home with some nursing care home, or they passed away in that setting. So some of the characteristics, they were on average 81 years old, 64% was female, on average they had 5.5 chronic conditions. And these are the percentages where they went, their first discharge. They mostly went to inpatient rehab. So something that I found interesting when I looked at the sex distribution, in most of the first settings, there's more females than males, because there was more females that presented with a fractured hip. But when you look who goes home, this is actually flipped. So somehow more males go home, and we can all discuss why that could be. Curious. And these are some of the different characteristics within each care trajectory. So we can, for instance, see where are the older people going, where are the younger people going. And I already pointed out some of the gender different, sex differences, and also with comorbidities. So the older people go to long-term care, and they also are more frail, likely because they have more comorbidities. So how does it look in the hospital? Well, here we also see that the more frail older people that end up in the long-term care, they wait for the bed quite a bit longer than the person who is sent home. If we then see how long do they wait for surgery? The people who end up in long-term care wait on average 50 hours for their surgery. And we know that if we have surgery after 24, we have all these risks for negative outcomes. And these studies are corrected for how frail you are. Whereas if you go home without formal care, those people only wait 28 hours. I'm not the expert. I understand there are some, things happening on the ground in these trajectories that make people have these delays. But it's very interesting to point this out. And this was also one that stood out to me. So who connects with their family physician afterwards? So the people who go to inpatient rehab, 50%, home with community rehab as an outpatient, also 50%. But people who go home without formal support, they seem to be a bit lost to follow up. What is the cost per day for each of these directories, and who died? So I just looked at, my main question was, where are the inequities? So the person who waits the longest is the one who is discharged to home with rehab and passes away there. And they wait an average of 72 hours. Who gets prioritized, or seem to get prioritized, is the person who goes home and survives, only 28 hours. And here I wanted just to, okay, we think they go home, we see where they go. Why is it so important to see the next destination? And here you see that. You can see that the person who goes home and survives had an average wait for surgery 27 hours. But the person that went home and died waited 34 hours. And you can see that their profiles are quite different. Who are these people that are old and frail and are sent home? We live in Mississauga. Half of our population is foreign-born. I can imagine this might be multi-generational homes, people who don't want their frail one in the hospital. But that's, for now, just a hypothesis. So take-home messages of what we can, with this type of research, we can identify high-risk populations, we can get insights into the health system performance, and identify actionable opportunities for follow-up and next step. We need to do some qualitative. Carrie and I need to talk. Carrie is qualitative, I'm more quantitative, that's why I'm saying that. What's happening? But this gives you a bird's eye view and a starting point. Thank you so much for your attention.
Fantastic, Judith. Thank you so much. Even though we work together, that's the first time I've seen the work on the care trajectories and the really interesting differences between different people that have hip fracture but have slightly different circumstances. Any questions for Judith on her really, really fascinating data? Okay, one second.
You spoke about some of the reasons why there may be differences from the baseline characteristics and differences. I'm thinking about the system-related differences, and I'm just wondering if you adjusted for provider in the analyses.
And provider at what point?
Like different orthopedic surgeons and...
No, at this point we just lumped them together, but I had the pleasure to fly here next to an ED, an emergency room physician, and she told me that indeed the comorbidities and the workup that needs to be done and maybe the technique they used and all that. So very interesting question. We definitely need to sort of dig a little bit deeper and see what's going on.
Great, thank you. Other questions for Judith? Oh.
I was just wondering if you noticed if your demographic of your patients has changed with COVID, because we've noticed that in our in a hospital setting, a lot of patients that would normally have a simple slip or trip are actually fracturing things that they didn't fracture before.
Mm-hmm.
And they've got capacity, they know what they're doing. I wonder if that's going to change some of the outlook.
Yeah, and very interesting. We have, this is over 3 years of data, and the first year is actually pre-pandemic, but so we can definitely look into if there's some major shift in who came. Yeah, thanks for that.
Fantastic, so we're at time, so thank you very much, Judith.
Thank you.
Marco White.
And we definitely have a multi-method follow-up study coming, or maybe mixed methods that we can work on, inviting other qualitative researchers out there. So now I welcome Fleur Visser to the stage, and she'll talk about prevalence and recognition of cognitive impairment in hospitalized older patients, a flash mob study. Very fascinating title. I feel like we're going to dance or something.
Well, thank you for introducing me. As you already mentioned, I'm Fleur Visser. I'm a PhD student at the University Medical Center of Groningen, the same as Sanne Tent from a previous presentation, and I will present you the results of our flash mob study. Previous studies demonstrated that between 30 and 50% of older hospitalized patients have cognitive impairment, and patients may have pre-existing dementia, may have developed delirium or delirium superimposed on dementia, or unspecified cognitive impairment. And the presence of cognitive impairment impacts the care needs of patients during and after hospitalization. Therefore, acknowledgement and recognition of cognitive impairment is necessary to provide integrated care. And patients with cognitive impairment have an increased risk for several complications and poor outcomes, such as dehydration, falls, infections, longer hospital stays, and readmissions. And if we recognize these risks, we may be able to adjust the care by, for example, taking preventive measures, involving relatives, and adjusting or arranging care after discharge. However, previous research shows indications of poor recognition of cognitive impairment. In a university hospital in Sweden, 200 older internal medicine patients performed a MMSE and clock drawing test, which are both cognitive tests. And if patients had 2 abnormal tests, it was recognized by 44% of the physicians and 64% of the nurses. However, limitations were that recognition of cognitive impairment was studied by retrospective medical record review. So they investigated whether it was registered in the medical records of the patients. And they did not inquire the healthcare professionals prospectively at the bedside. Therefore, the aim of our study is to investigate the prevalence of cognitive impairment in hospitalized older patients, as well as the recognition of healthcare professionals, but then with prospective data collection instead of retrospective medical record review. To study this, we performed a flash mob study, and this is a quite new way of conducting research to answer a relatively simple but clinically relevant research question in a short period of time and with a large group of data collectors, the mob. We performed a flash mob study on World Alzheimer's Day last year, and we did this in 13 hospitals in the Netherlands. And in every participating hospital, healthcare education students and hospital staff, they helped us with the data collection, and they approached hospitalized patients who were 65 years or older, and they asked them to perform the mini-COG. And the mini-COG is a 3-item word memory test combined with a clock, the clock drawing test, and this test is especially suitable for the flash mob design since administration requires minimal training, and it takes less than 5 minutes. The second part of the data collection was that the data collectors approached the physician and nurse of the included patients, and they asked them whether they thought the patient had cognitive impairment. One advantage of the flash mob design is that data collection draws a lot of attention to the topic. So we may already have raised awareness about cognitive impairment in the participating hospitals. And by involving future healthcare education students, they might have get a little bit more awareness about the topic as well. And we did not scientifically study this, but healthcare education students were surprised that quite some patients were able to have a seemingly normal conversation, yet they struggled to draw a clock. And for the scientific part of our results, 1,318 patients were available on the day of data collection, and some of them were excluded because they were unable to perform the mini-COG due to severe sensory impairment or severe illness, and some were not willing to participate. Finally, we included 757 patients. The median age was 77, and 49% were female, and 89% were from a general hospital compared to university hospital. And 65% of them were admitted to a medical ward and the others to a surgical ward. And the medical disciplines with the most included patients were surgery, internal medicine, cardiology, neurology, and pulmonary medicine. Most importantly to say is that the included patients did not significantly differ from the excluded patients in terms of age, gender, and the medical ward they were admitted to. Then the results of cognitive impairment. All included patients finished the mini-cog, and 46% of them scored less than 3 on the mini-cog, indicating cognitive impairment. So that's almost half of the older hospitalized patients. And here you see some of the clocks that were drawn by these patients. The difference between the groups who had an abnormal mini-cog and a normal mini-cog were that they were older, a higher proportion was female, and a higher proportion was from a medical ward. Cognitive impairment was recognized by both their physician and nurse in 32% of the patients. 60% was recognized by the physician only, and 10% by their nurse only. But most importantly, 42% of the patients was not recognized by their nurse or physician. This figure shows on the x-axis the mini-cog score groups, and the bars represent the percentage of physicians and nurses that thought cognitive impairment was present. And the worse the mini-cog score, so 0 is the worst score, the better the recognition gets, but still for the group that scored 0, the percentage is only between 60 and 70%. And in all the mini-cog score groups, the physicians were more likely to think that their patients had cognitive impairment compared to nurses. So also the groups 3, 4, and 5 from the patients that had no indication of cognitive impairment. This figure shows the recognition by physicians and then divided per medical discipline. And the medical disciplines that work most extensively with cognition do recognize cognitive impairment better. So those are the geriatric department and the neurology department especially. And for the other groups, the other medical specialties, the recognition rate was lower. Our study, of course, has some strengths and limitations, and one of the important strengths is that this is the first prospective data collection on cognitive impairment recognition, and it is a national study including both university and general hospitals, and we studied recognition by both nurses and physicians, and data collection may already have raised awareness about this topic. An important limitation is that the mini-cog provides an indication of cognitive impairment and no diagnosis. So as a result, we were not able to distinguish between different causes of cognitive impairment. And another limitation is that we have heterogeneity of data collectors. However, we used a shared instruction, and the mini-cog can also be performed by non-healthcare professionals. So this effect might likely not be, well, that important. To conclude, cognitive impairment is common in hospitalized older patients, and it is poorly recognized by healthcare professionals. Healthcare professionals need to look beyond the diagnosis of their own medical specialty, and they need to be aware that the cognitive performance of older hospitalized patients may be worse than they assume. To provide integrated care, quality improvement in the recognition and acknowledgement of cognitive impairment is necessary. I want to thank all the collaborators of this project, Rikje from Maastricht Ziekenhuis, also here in the room, and I want to thank you for listening.
Thank you very much, Fleur. Really, really interesting study and an opportunity for practice improvement in terms of recognizing cognitive impairment among people using the hospital. Any questions from folks in our crowd today? Oh, okay, Judith, and then.
Thank you. Thanks for this awesome presentation and a great way to study. I was just curious on what you think why physicians were a bit better, because as a layperson, I would think the physician sees the patient way less.
Yeah. Yeah, well, I think they are a bit more, or I think nurses are a bit more naive than physicians. But this is not the same as with previous studies, because in the other study, the nurse percentage was better. Yeah. But yeah, it can also be because this is another country, and the Netherlands can be different from Sweden. But yeah, there's still discussion about that. So maybe you have got ideas.
Yeah, thank you very much for your interesting presentation. I had some practical questions because I'm very interested in the design of your study. So can you tell a little bit more about how you recruited the hospitals and the data collectors, and how they were instructed, and if you need informed consent, such things?
Yeah. Yeah, well, I can talk for an hour about all those preparatory stuff. Well, what do you want to know most?
Then the recruitment of hospitals and data collectors.
Yeah, we put an advertisement in newsletters of internal medicine newsletters. We recruited colleagues via geriatricians, internal medicine physicians, and I had a lot of meetings, online meetings mostly, with people who were interested to explain what they had to do when they wanted to participate. And every hospital was responsible to recruit their own data collectors. But we had, because I'm in the Abort project, that's a national project in which we do research on dementia. We also have colleagues who work at hogeschool, and they had a lot of connections with other nurse education instellingen. So networking is an important part, and the patients needed to provide informed consent, and it was very hard to keep that in a small form, but but it is in the same time keep with the regulations that were provided from the medical ethical committees. So yeah. But I can tell you a little bit more about it. Yeah.
Thank you very much.
Thank you. So we have time for another question, if anyone has. Yes.
I have a little bit. I don't. Just let me ask you the question. I see also the dancing on the topic. Can you show us a little bit of the dancing, or do they do some? Well,
there was one very fanatic hospital that also made a dance, and they organized a whole event around this day. So I did not dance actually, so I cannot show you. Very disappointed. But well, every hospital made their own.
Because
event.
I think that helped to do the awareness, to reach the awareness. I think,
I think that also contributed to getting attention to this subject in that hospital. But yeah, it depended on the hospital how much time there was available to organize all those things.
And what kind of other things did they organize?
Mainly newsletter parts, and in our hospital, we met, especially in the nurse education institutes. There were training programs about how to recognize cognitive impairment and what is cognitive impairment. So I also did an instruction at the Hogeschool in Groningen. So mostly education or dancing in the hospital.
Thank you. I think my neighbor was.
Did you supply them with ideas to or was it their own?
Not really, but I think I would do that if I would organize another flash mob. Yeah. I learned a lot from organizing this, and those things are, good to take away for next flash mob.
So we're at time, but I will welcome one more question to sneak in.
Hi, thank you. It's a really interesting study. I just wondered did you manage to consent the more vulnerable patients? I know an awful lot of the patients did have cognitive impairment.
Yeah.
But was there any feeling that patients that were concerned they may have cognitive impairment were unwilling to be recruited?
Yeah, when thinking of capacity and assessing capacity of vulnerable patients, it's also important to think of what you ask them to sign consent for. And this is only the mini-COG, which is a part of normal hospital assessment in some of the departments. So the very ill and cognitively impaired people, we were not able to include them in the study, but I think that compensates with the people who were not willing to participate because they thought, well, nothing is wrong with me. There's a line, and the very severely impaired people we weren't able to include, but the others, we thought they were okay because it was only a mini-COG they consented for. Yeah. Is that okay with?
We have the microphone.
30 seconds.
Just some similar work that I was involved in. I found some of the vascular patients, for example, who may be drinkers and smokers, didn't want to know whether or not they had cognitive impairment. That's what I was sort of getting to, and whether you had the same issue. It's just interesting whether that's a cultural thing or whether you had the same problem.
What do you mean? I'm sorry, I didn't understand the question.
If someone's concerned they may have cognitive impairment, they refuse to do the assessment. Was that an issue?
No, I don't think so, because they were in the hospital and there were possibilities to getting them assessed whether when they were concerned. Yeah.
Thank you. That's it.
Yeah.
Great, thank you so much. That concludes our session for today. So join me in giving a warm round of applause for all of our speakers. We heard about care trajectories. We heard about the need to recognize cognitive impairment and sensory impairments like hearing impairments. We learned about goal facilitation tools and different interventions involving caregivers. It's really hard to sum it up, but I learned so much, and I'm sure everyone did as well. Thank you so much, and I think now we can enjoy lunch and a bit of networking, and I know we all want to do research with all of you, so we're going to probably come after you with more questions. So thank you very much.
Okay, lovely. Well done.